Introducing Dr. Robin, who is a medical doctor and telehealth technical expert from France, and he specializes in public health. He's currently working with the WHO, developing telemedicine programs in the Pacific. He is a co-founder and director of the consulting agency Telemedicine 360, and has conducted several works on telemedicine policies, and most recently has published a global call to action for telemedicine integration in the pandemic responses for COVID-19. I officially now hand over to Hannah to start the sessions. Vinaka.
Thank you. Now I'm going to hand over to Dr. Robin.
Blanky.
When you're ready to present your slides.
Yes. Can you hear me?
Yes, we can.
What is it?
There you are.
Okay.
We can see and we can hear you.
Okay.
Ah, there. It's just a house where people want to go.
There we go.
Yes. Good afternoon, everyone. Happy to be with you again today for this second session of the series on telemedicine in the Pacific. Today, I will be presenting on establishing national telemedicine programs, so in a more broader approach than yesterday, which was more clinical and technical approach for healthcare professionals. Today, the objective is to give a broader understanding of how this clinical daily activity can fit or can be promoted by an overarching national promotion and push towards integrating all those activities into routine healthcare every day and with time. So I will now share the screen. Okay, could you please confirm that you're seeing well the slides?
Yes,
Yes,
can see.
Okay, very good. So thank you again for the network for organizing this session and for inviting everyone, as well as WHO Western Pacific Office and especially Katri as well for coordinating this, and Dr. Davina for the kind introduction. Yes, so for those who were not there yesterday, I just wanted to briefly outline again the overall context of telemedicine and telehealth globally in the world. So we got an increase in the last decade, mostly in Western countries, which developed several kind of telemedicine activities. And we've seen a sharp increase during the pandemic due to mostly lockdown effect and impossibility to follow up patient and ensure continuity of health services. And therefore, this is why telemedicine increased, which is what we published way before in 2015, and as well last year with that global call to work on those activities. Then the question is, how do we move forward for the next decade? So in the world, what will be the different options? We don't know yet, but we can promote the way to increase it for the benefit of patient and population health. However, in the Pacific, the situation was a slight increase during the pandemic, but still not a massive increase everywhere in all the countries. And this situation can be related as well to the fact that there was no existing legal or strategic infrastructure or national program at national levels. And also that options that may have been implemented during this time were not as well implemented because of the maybe lack of capacity or lack of acculturation with the topic. And this is why WHO initiated this project as well, to initiate, bring the capacity, culture, training, and so on. And this webinar is the one of the results today. So the objective is that we don't stay in the red line for the next decade, or maybe orange, but that we keep on the blue line, and that the Pacific region has, as the other regions of the world, an increase in telehealth and standard telehealth activities for routine care. So it may sound ambitious, but it is possible, most notably because the size of the countries are smaller, so it's easier to manage if there is um, national will, and also due to the remoteness of the situation in the islands, the need is even more higher. So those combinations should be a good catalyzer to go forward. In that sense, national telemedicine program can drive the growth for the next 5 years. And in this regard, they should be considered as a key strategic options for countries and health authorities to consider in the next months. Why is it important? Because you can have in your countries different initiatives, different projects from public sector or private sector. However, if there is not some kind of integration or direction somehow given, then all those efforts will not be coordinated and will not go to the same to reach the same objective. So this is why this is very important to define those strategies. So again, like yesterday, how do we start? How do we go from zero to having something established? So we listed few steps that we've seen have been beneficial in driving those activities in different countries, and that can be replicated as well in the Pacific. So the first activity is to set up a national governance. This governance means that there is someone or some group to drive this strategy and to this program, and to have the key accountability and responsibilities for it. The second point is to check the existing legal frameworks, because telemedicine activities as medical and healthcare activities usually fall under healthcare related regulations, and therefore are submitted to some kind of regulatory approvals or formalities to do. So therefore, it needs to be checked to know what is the current situation. Does the existing legal framework is supportive of telehealth activities? Are there any gaps, and so on? The third point, which can be as a first point as well, it's not necessarily in the order, but it could be easier in that order, would be to perform initial readiness assessment, meaning where do I stand for my country as my national telehealth landscape? So do I have strategy? What is my framework? Do I have human resources capacity, financing capacity for this? Are there any existing projects? And so on. I will go in details of all of those steps. The fourth point is to define the national strategy. So you cannot define a strategy like this from nothing and say, okay, we'll just write some key actions. You need to know before all those 3 steps, because it will give you the context and the necessary information to define what will be your own priorities. Because every context, every situation has different priorities, and you cannot just copy other countries' strategies. And lastly, it's about promoting and supporting projects. So if you define a strategy, but then you fall short into promoting the implementation of projects, specific project like we discussed yesterday, then the strategy will be just another administrative document. So it is really important that within this strategy, you define as well how you will promote qualitative projects. How will you support stakeholders and healthcare professionals and healthcare facility in implementing projects, and how you will continuously improve the quality of those projects. So altogether, those five steps can give a starting work plan for anyone who would like to establish national telemedicine programs in this regard. So regarding the national governance, in few words, what can be done and how it could be done. So the idea is to assign a group which will be responsible to lead at the national level the growth of telehealth with dedicated terms of references. This group should have their roles and responsibilities clearly defined to know what they are accountable for. Their process for project assessment and support should be defined as well. So if you receive a new project request, who is taking care of this, how should you reply, and so on. And as well inform all stakeholders of the existence of this group, because it's important that everyone knows that all things related to telehealth and telemedicine needs to be channeled and addressed to this group. In this way, it will help to gather all capacity and expertise in one point, and to work in collaboration with all the other expertise or technical groups. Why is it important? Because in telemedicine, we have different types of needs. There are medical needs. There are scientific needs. There are IT and technological needs. There are regulatory and legal needs. And all of this needs to be combined in one group so that everyone works together. Sometimes it can be through the IT department or medical department. This does not really matter under which or who is it under. This is for you to decide. But it's very important that everyone that is impacted by telemedicine is included into that group. Therefore, there cannot be, errors to drive it through only purely technological work or purely medical work without considering technology, and so on. So I would like to give you here some examples. Firstly, I'm happy to share with you the example of Fiji, where the Ministry of Health and Medical Services defined a national telemedicine advisory group in February 2021 with the support of WHO. This establishment of this group was promoted and initiated alongside. Hello? No? Okay. Alongside this project, and I saw that Dr. Eric Rafai, who is leading this group, is part of the participant of this webinar. So maybe once I finish, he may be able to give additional detail from his perspective and personal experience so far with this. That could be interesting as well. Other example in Singapore, so they established a National Telemedicine Advisory Committee within the MOH as well in 2015 with the goal to develop initial telemedicine guidelines at that time. And this organization helped them to go through the COVID. At a state level, because I know as well in the Pacific, there are so federated country. So in Australia, in New South Wales state, they created a telehealth strategic advisory group, the New South Wales group, in 2016. And this group was created within the Agency for Clinical Innovation, the ACI, which is also somehow dependent of the MOH, but they decided to put it under more the clinical innovation and medical leadership rather than technical leadership. And some other examples from Europe. So in France, for example, there was firstly a department dedicated to telehealth, which was created within the Ministry of Health. And this is headed by both a medical advisor, so it's a medical doctor, and an administrative director to drive all the regulatory, technical, funding activities. So it's led by those two people. And they have as well a national telehealth committee that gather every semester or every 3-4 months to update all the stakeholders on the progress and update of what has been implemented. Another example from Ireland, which did not have any national governance before the COVID, and in 2020 they established a National Telehealth Steering Committee within the Health Service Executive, the HSE, which is the National Public Health System. So I wanted to show you here different environment, different countries, a different approach, different style. So everything is possible, but at least they have somehow a group that is nominated, dedicated to drive forward these activities. Then let's go to the legal framework. So the objective of checking the legal frameworks are diverse. The first one is to identify all potential legal barriers to remove. So in some cases, in some countries, there may be some barriers, and therefore they should be removed. In other situation, and this is actually the most probably the majority of the cases, it's legal gaps that needs to be addressed. So telemedicine activities imply a new type of questions regarding liability, responsibilities, data confidentialities, and those aspects are usually not existing into the national legal frameworks, and therefore it's not blocking any activities, but it's not as well supporting because we do not know what to do. So those are gaps that needs to be addressed. And yes, and additionally, to identify the processes to update the legal frameworks accordingly to those gaps or those barriers. So we all know that changing regulations or changing law or guidelines is something that takes a long time. So in order to be efficient, it's really important in terms of strategy as well to know what will you do and how will you do this to change what needs to be changed. In terms of content to check, so it's just here to give you a few examples. It's not exhaustive, but there are terminology, licensing and liability, patient and professional identification, patient consent, especially if it's done online or remotely, medical prescription, especially online prescription. Is it authorized, not authorized, in which condition, etc. The medical record, so should it be accessible, shared, mandatory? Data privacy and security. For telemedicine activities, mostly the data are stored online on the cloud and mostly outside of the countries of the Pacific. So there should be also questions regarding this point. How should it be addressed? And lastly, funding models. So majority of the Pacific countries have public health system with public funded system. But in some cases, if there is a collaboration between different doctors or hospitals, then it may be discussed how this financial flow are being addressed. So some resources and options. We've seen this in many countries in the past year that issued legal waivers or defined regulatory sandbox to allow the temporary use of telemedicine under some provisional regulation until the time comes to define a more long-term and sustainable approach. But at least that helped in the first months to initiate something with some kind of legal basis. And there was WIPRO guidance, here I put the title, that could be as well resourceful for you to consider in this regard. Some example as well, this is not exhaustive, it's just to give some ideas. So in Australia, they had already existing telehealth items under the MBS scheme. So it's the funding schemes, but there was some limitations. And so they extended the scope during the past year to include more funding activities for telehealth. In Indonesia, they had a previous regulation for telehealth, but only between health facilities. And last year, they did a temporary extension for the emergency through an MOH letter and medical council guidelines, so kind of soft law approach. In Brazil, there was a long fight, legal fight for years between the doctors and the health authorities, which first authorized, then did not authorize telemedicine. And finally, during last year, the MOH put an ordinance, so it's not a law like parliament law, it's MOH document for temporary use. In India, they chose to have a national guidelines. So they gathered everyone, defined that guidelines alongside defining a national platform as well, which was very successful. And in France, we had pre-existing regulations since 2010, pre-existing existing funding since 2018, but the scope was limited in terms of what type of telemedicine activities can be funded, and those limitation was removed during COVID and now being extended since. The next point is the readiness assessment. So the timing could be either now to know what is your current situation, or when there is a need for transition from emergency to more long-term approach. However, I would recommend to do it as soon as possible to have a clear vision of the current situation. The objective is to have a macro view of the national readiness to support the definition of the strategy. And the method that we defined was an external evaluation through interview of key expert team from the country. And in terms of content, there are 9 sections with yes/no question, and we defined an algorithm to define for each of those sections the readiness and the actions that could be taken to mitigate the situation or improve the current situation. So I'm happy as well to share this information with you that we conducted a first national assessment with Tuvalu this month with the expert team, which took us around 2 hours of remote interview with a group of key experts, and which was followed by internal discussion and then a debriefing session, which will actually happen just after this meeting. So this was as well great. So I invite all the other country to engage in this direction. The document will be released soon, but if anything, this can be as well initiated. Next point is the national strategy by itself. So it should be considered as a national strategy document, and it has to be aligned with the national health and digital health strategy. Often we see silos in telemedicine or digital health with standalone activities or standalone projects which do not integrate with the national digital health infrastructure. And even if this is easier to create at first, it may create as well more long-term issues for integration. So this should be carefully thought of, discussed and planned to see how to align all those activities. It should be definitely through stakeholders consultation, because it involves many types of different stakeholders. It needs to have some priorities and plan of action, and as well include the funding dedicated to implement the strategy. Mostly we see a very well strategy document. However, it's not defined where will come the money from to implement it, and exactly the plan of action and who is responsible for each action. So this is really important as well to include it, and that could be linked with the national governance. One example from France I wanted to give because it was very medically oriented. We had a national telemedicine strategy defined in 2011 with 5 key priorities. So actually the process was that in 2009 there was first a law that was accepted in Parliament to define legally telemedicine. Then in 2010, there was the legal provisions that defined all the legal conditions to practice telemedicine. And then the year after, the national strategy was defined with key priorities, which were teleradiology, which 10 years ago was almost non-existent, and now today is a routine activity everywhere. acute telestroke, non-existent, now everywhere. Telemedicine in prisons, which was existent a little bit and now is improving, but not yet everywhere. Telemedicine in nursing homes, which was non-existent and is now in majority of nursing homes. And telemedicine for chronic diseases, which led to serious, several pilot projects, especially on more remote patient monitoring in diabetes, heart failure, and so on. So this was just one part of the strategy, but wanted to share with you the medical priorities because they considered that that was their priorities at that time. However, I would strongly suggest for the Pacific region to go much faster than what was done in France and Europe before, and to integrate all of this in a more quicker approach, because now we know the lessons from the past, the errors to not repeat. So I would advise in this direction. And then finally, for promoting and supporting projects, there are 5 components to consider. First, education and training. So for all healthcare professionals, initial training, continuous training. So this needs to be considered in relation with medical universities, nursing school, and so on. Clinical guidelines to promote quality. Project management guideline, so to support how to implement each project and templates. And we have been working or starting to work with Fiji as well on this. A national observatory to monitor the growth, know which activity, which specialty are growing, which one have more difficulty, what are the problems faced to continuously improve the strategy, and as well direct technical support to help the project leaders in this area. And yes, and in this regard, we initiated as well some. There was some support this kind of activity in FSM as well that was initiated. And to finish, I wanted to give, quickly 2 notes, one on business model and one on procurement. For the business models, there are mostly 4 types of business model that can be applied. I know that most of the countries in the Pacific have global budget approach. And therefore, for telemedicine, the advantage is that you don't need to negotiate the price of each new telemedicine activities. It's part of the budget received. But therefore, if there is a need for investment, whether in time or hardware or software or project management, then this is an investment. And in this regard, then you need to find where this investment comes from. In other models, which are fee for services, which we have, for example, in France, each telemedicine activity has its own item, price, and cost. So it's same in a similar model in Australia and in USA, for example, in MBS in Australia and CPT code in USA. However, this creates complications because you have to define for each one a type of code and a funding, and you need to have coding, so it's more complex. Another approach is revenue sharing model, which means that if you have 2 entities, 2 hospitals or 2 doctors collaborating for one patient case in telemedicine, the revenue that should be for one is shared with the other one. So the practical example is in teleradiology. Let's say you have a patient, that have a CT scanner in hospital A, and that CT scanner is interpreted in hospital B. So the hospital A will get the funding from government, and then hospital A will give some part of the funding to hospital B for the reading. But this implies that negotiations needs to happen to know what percentage is shared, how much, in which conditions. And lastly, one of the model is capitation-based model. So it's payment per patient for duration of time. So let's say that it's well applied in remote patient monitoring. You can say, I do remote patient monitoring of diabetes patient for 6 months, and therefore the price that as a hospital I will receive is a package for that 6 months. It doesn't matter how many times you see the patient, what happens, it's for you to organize yourself how to do it. But this is as well, it has as well some complexity. And the final note I wanted to give today was regarding procurement and providers and some advices really important that needs to be considered when dealing with providers. First one is that always define your medical project and needs before starting your procurement. Most of the time we see organization which first will go to a software or hardware provider saying, I need this, I need that, but the medical project and needs is not defined. Therefore, you have potential risks to have a solution which actually does not match exactly your needs. And then this creates huge problems. For example, yesterday in the teledentistry project which was presented, firstly, they decided to go through three different apps to build themselves the pathway, to understand what is the needs at each steps. And then once this will be piloted and evaluated, to decide, okay, which solution do we go through? Do we develop one? Do we buy one, etc.? The second one is to always perform a national or international benchmark before choosing the solution. So if you want to take a solution for teleradiology, don't go with the first one that is knocking your door. Always check different prices, different approaches, different services. Only in teleradiology, for example, there are maybe more than, I don't know, 20, 30 international companies that exist with different models, different price, different qualities. This needs to be checked, that you know exactly what you want to take. Once you have moved forward, always test the solution before buying, because we've seen as well many places that were some kind of lured by the startups or company technology, but when actually starting, there was a lot of things missing. Then once you have selected, always start with a pilot phase before engaging for a long-term contract. I would recommend to not sign like 10 years contract from the start, but first pilot it for a few months, understand the needs, the volume of activity, the problems. Then you have better negotiating power with the provider. And usually, most of the time, they're willing to do this phase because they know as well that they have to adapt. And lastly, always check for maintenance and upgrade conditions before signing the contract. This is really important because telemedicine software evolves every day. And some companies can charge you for those upgrades and maintenance, and some include it into the fee. So if you have subscription model, then for example, the subscription will remain the same and they take into account themselves the upgrade. Some other company, you buy a solution now in 2020, but if you want the upgrade in 2021, you have to pay more. And if you don't pay more, you keep with the old version. So this creates as well other problems. So really practical advices as well for procurement for your national telemedicine program. To finish, I wanted to say that telemedicine is essential to reach essential health coverage and ensure access to health to the whole population. And that, yes, you can do it, same as yesterday. Everything is possible with strong will, motivation, and capacity. This can happen, and I will be very happy to support you by any means possible in this regard. If you need support from WHO, please contact Katri Contio, who is the responsible for digital health and health information system. Her email is here. Please contact her if you need support from WHO. And with this, that would be my last slide for question and answers. You have my details and you will have it later. Thank you, and I'm happy to get questions. Thank you.
Thanks, Dr. Robin. That was brilliant and very informative. And I saw there was quite a bit of chat going on in the chat box. Does anyone else have any questions that they want to ask before we close out? All silent. Okay, I think we're good. But as mentioned, you can email through your questions, and also when I send out the email tonight with a link to the recordings for both this session and yesterday's, you can email through any questions, and they'll get forwarded onto the right person. So thank you to everyone for joining. Really appreciate it. Yes, I see a hand going up.
Yes, I can see that Dr. Rafai is connected here from Fiji. Maybe if he wants to share his experience for the technical advisory group, that could be maybe interesting for the other ones. If not, no problem. It's just a suggestion.
Thank you, Dr. Robin. I think you wanted me to say something. So thank you, Robin, Devina, and Katri. Basically, with the support of Robin, we found the tag. We used the tag from Australia, the terms of reference, and then adapted it for our own use. I guess our telemedicine group is actually hosted by our research and innovation unit and chaired by our chief medical advisor. And the purpose we had, the reasons for that is that we are having so many projects coming in, telemedicine and chronic diseases with Dr. Divina and Katri. We also have SRH proposals with UNFPA coming in. And finally, we also have started on teleradiology, in which most of our clinicians don't recognize is actually part of telemedicine. So the reason why we set it up under research and innovation was because there are processes and important elements within clinical practice that need to be considered. And what was raised yesterday is most important. We still have to maintain confidentiality and privacy. And that's key. Even though we are using the technology, it's important that those guidelines are also sustained throughout. So this group exists. We are trying to review these many projects as are coming, trying to utilize the opportunity with the COVID situation. Thank you, Dr. Robin and the organizers.
Thank you for your input there. That was much appreciated. I think we'll leave it there. Thank you everyone for joining. And as I said, look out in your inbox for the email, which has the links and the slides from the presentations today and yesterday. Thanks everyone.
Thank you. Bye-bye.
Thanks. Bye.